But I currently serve as the Chief Exec of ASCP, and of course our offices are in Chicago. And we are going to talk about a very important initiative that occurred several years ago, and that's the Choosing Wisely campaign. And that's in tandem with the American Board of Internal Medicine, and as Eric mentioned, also funded by the Robert Wood Johnson Foundation with respect to a granting opportunity to forge ahead with this education. So why are we discussing Choosing Wisely, and what exactly is it? It's a campaign really that was spearheaded by ABIM in order for us to consider how we as professionals throughout any subspecialty area of medicine should help influence changes in the system that can both obviously allow for decreased costs, but also to increase the sensitivity of the testing that's occurring within the medical community. Now, obviously, we aren't always the individuals who will choose the tests, and that's why it's a little atypical for pathology to be at the table. But the irony is that when we first started this discussion with ABIM, as you know, greater than 90% of diagnostics are done by the laboratory. But yet they were discussing inappropriate testing without the laboratory at the table, which was actually an interesting scenario. So when I approached the ABM about joining this campaign, they were euphoric because they really need pathology to step forward to serve in the consultative fashion. Ergo, that's why we're here. We're here to think beyond the laboratory, and our healthcare system is moving really to a model that maximizes efficiency, as you know, and with those changes in the delivery, the reimbursement approaches as well are obviously going to be changing and modified associated with accountable care organizations. But it's our importance, our fiduciary responsibility to the patient to do the right thing, right? And it's our responsibility to make sure we require the appropriate diagnostic test and that we are actually performing the right diagnostic tests. I tend to remind folks how the American Society for Clinical Pathology got its name. It was the American Society for Clinical Pathologists because pathologists used to be clinicians in 1922. And as such, they were the clinical folks who actually chose the test and were on the front line helping patients get the appropriate test at the right time. Obviously, our field has tremendously exploded, but we're sort of coming full circle in terms of our ability to be important players in the consultative fashion with the clinicians, and obviously that translates down to the patient as well. So we've got to lead when it comes to diagnostic services. We've got to be involved in helping advance patient-centered care. We've got to think about it through the scheme or through the lens of improving overall healthcare delivery and reducing unnecessary utilization. That is, reducing the types of tests that aren't necessarily critical for that patient per se. We're going to be regarded, and hopefully we will be rewarded as much as for what we don't do as for what we do. So there's an opportunity for us in this profession. And that opportunity is for us to use better, more effective models of laboratory services and using those delivery models such that we can optimize quality and reduce costs simultaneously. Now, you can see the schematic here where there are multiple impacts or factors that impact the quality paradigm. And that includes, obviously, safety, effectiveness, efficiency, et cetera. All of us know about lean technology and lean management in our laboratories. Timeliness is important as well. But all of it obviously has to have a patient-centered approach. But quality is impacted by multiple factors. So in terms of optimizing quality, obviously we would like to see more rapid diagnostics and treatment and patient-centered management, allowing for effective treatment. But in terms of reducing costs, we're very interested as a profession for reducing unnecessary and actually potentially sometimes dangerous interventions that are unrelated to the actual diagnosis or, for that matter, for what the patient is being worked up for. So we would like to look at shortened times for treatment, and obviously patients win. So just remember, it is a quality issue with multiple factors, but from our professional standpoint, making sure that we optimize that quality and reduce costs are critical. So this campaign, as I mentioned to you earlier, really is to bring all of subspecialty society medicine together, from cardiology to internal medicine, family practice, anesthesia, you name it. Pathology, obviously, is a critical player at this table. And I always like to remind folks that if you think about pathology from a metaphorical sense, we are the trunk that allows for the branches of all clinical medicine to occur. And the roots, of course, are genomics and biochemistry, et cetera. But we are the trunk that supports all of clinical medicine. So it's critical that we, as a diagnostic area of medicine, that predominantly is involved in the lion's share of diagnostics, should be helping clinicians make better choices. So it's really to help get to that point. But who is the downstream player? Well, it's the individual in the middle, which is the patient. And the patient has to be the individual, obviously, that will be the beneficiary of all these decisions. So we critically have a responsibility to make sure our patients get the right tests at the right time, and it's the right patient. And hopefully, you can look at as well if it's the appropriate cost. So this is a campaign that really looks together in tandem with all subspecialty medicine, referred to as Choosing Wisely. We also partnered with Consumer Reports, and you're going to get a chance to hear from Becca in a few minutes about why Consumer Reports is so critically interested in this issue around choosing wisely. I don't have to tell you about how important that organization is and what they do. They reach hundreds of millions of different consumers, which can influence consumers' choices and obviously help patients make better decisions by bringing it into the limelight why choosing wisely is such a critical piece. And this was also performed or done in tandem with AARP. So today we really want to engage in a dialogue between patients and others. We want to engage in a dialogue around choosing wisely to use it as a platform, an opportunity to allow us as leaders in pathology to really help have a positive clinical outcome and cost reduction, identifying techniques for influencing the clinicians choosing the best tests, and identifying methods for really overcoming communication or organization or any substance barriers that prevent the choosing wisely practices from actually being implemented. So today here are our cast of experts. To my right, immediate right, is Becca Rothschild from Consumer Reports. She will come on in a few minutes after I do. And we have Richard Kravitz, who is a professor of medicine at UC Davis. He's going to be discussing how can pathologists influence better test ordering. We have Haya Rubin, who is also going to be discussing from internal medicine. And then there's also going to be a tremendous discussion, hopefully, by our former president of ASCP, George Lindbergh, who is going to be looking at the big picture of how choosing wisely can really be an overarching opportunity for us as a profession to propel and catapult us forward. He obviously is with Medscape, and also he'll describe for you some of his work with relationship to genomics. And in the wrap-up, we'll be back with Dr. Parks with respect to our post-campaign. Now, here is a list of, and you may not be able to see all these, but here's a list of all the organizations that have decided to engage in choosing wisely. There was actually 2 or 3 phases. The first phase was about a dozen or so. The second phase was another 18 or 19, which we were involved in. You can see we were in the second phase, ASCP. And then the third is currently undergoing or being matriculating at this point in time. But you can see it really runs the gamut all across the specialties of medicine, and hopefully there's going to be tests or there's going to be recommendations that are in common with those that are important for what we do in pathology. Now, ASCP sits on the Council of Medical Specialty Societies. We're the sole representative to that society, and that's all the societies that get together and meet 3-4 times a year to discuss issues related to the practice of medicine. And so we were requested to be the player or be the organization to support this campaign, and we gladly agreed. So let's talk a little bit about inefficiency. This isn't news to you. The Institute of Medicine has reported that 30% of healthcare actually is duplicative or actually unnecessary. And Paul O'Neill recognized this when he was CEO of Alcoa. You know that inefficiency threatens our nation's ability to deliver the highest possible care to all patients. It's been stated that by 2019, that the GDP will be eclipsed by healthcare spending, almost 19.6%. Think about that. Think about that. Almost every quarter of our taxpayer dollars will be consumed by healthcare spending. And some of this spending, as we're going to describe for you, is unnecessary. So pathologists, lab professionals, and we describe those as the non-physician practitioners because ASCP also represents the entire laboratory. So we also want to look at how laboratory scientists, medical laboratory scientists, all the way down to phlebotomists can be involved in and hopefully contributing to the importance of prevention of overutilization of laboratory assays. This is why we joined the particular campaign. Now, you're leaders. And as laboratory leaders, you're constantly looking to, again, improve patient care. In hospitals, pathologists, lab professionals serve on many committees and task forces. How many of you, just give me a show of hands, how many of you in the room also concomitantly serve on any kind of a task force or any kind of committee for your academic medical center or for your private practice group or whatever? Almost every single person in the room. Okay, now that was sort of a seeded question. But when you raise your hand, you need to think about the fact that you can help us as a profession prevent overutilization of laboratory tests. So unnecessary testing or inappropriate treatment decisions of consummate or finite resources is a clear objective to prevent. Now, this isn't news to you either. You've probably seen this many times, but our country is also being eclipsed by many countries around the world. I could list a number of them here for you. I'm just going to throw the U.S. at the end, and you can see, if you look at the top line basically is life expectancy. So life expectancy is not as high in our country as it is compared to countries like Japan, Sweden, even Italy, Germany, the UK. But we're at the bottom of the totem pole on that, if you look at the life expectancy. But look at what we're spending. Almost 3 times more than many countries. In fact, some countries, including Spain and others, spend 1/5 of what we do on medical care, but their outcomes are better, have better outcomes. So the U.S. is spending more, but people aren't living any longer. So we've got to balance that expectation. Obviously, the curve should be reversed. So again, one initiative is to seek a reverse in that trend by reducing costs and provide no benefit to help mitigate tough decisions about what care is necessary. And to help mitigate those decisions, we should be working in tandem with our clinician partners to help to deliver that particular algorithm. Here's a quote from Leonard Freeman, from Feldman, that is, from Johns Hopkins. And he states that most doctors have no idea what these tests cost, so they have no way of knowing that they're contributing to the astronomical cost of healthcare. How many folks in the room would agree with that? So order a test in batches and check off a box, a whole battery of tests, and they don't understand the ramifications to the healthcare system. And a lot of these tests that we're describing are high volume, although relatively low cost, but high volume tests, right? High volume tests that may not necessarily be important, and oftentimes they don't realize that they're overutilizing these tests, and they think that, in fact, that they're not that expensive either. So there are many dimensions really to appropriate test utilization. When you center appropriate utilization on good patient care, that includes the cancellation of these inappropriate tests and maybe the choice of the appropriate tests by helping clinicians choose those. So, you could look at it from the standpoint that we know in our laboratory practices every day that there are myriad tests that are probably overutilized. Okay, but what are we doing about it? And when we were asked by the ABIM to develop a list of our tests, they just said, "Well, give us your top 5." Like, top 5? We started with 300 or 400. It was horrific. We were having a very hard time just to whittle it down to 5. But I'm going to show you in a few minutes why we chose the top 5 that we did. They may not actually have any relationship to each other, but you'll see why they were chosen. And actually, it was used and leveraged to help Choosing Wisely Part 2, Part 3, all the way downstream. You're going to see this continue to occur. It doesn't stop here. This is just the beginning of the tip of the iceberg. So, Obviously, we chose 5 tests, and I'll show those to you in a minute. Patients should also learn firsthand about these tests and make informed choices. And I was having a nice conversation with Becca at lunch about the importance of a journal or magazine like Consumer Reports in a company like that who reaches so many folks. Folks are taking proactive choices in their health care. And in a female who's had a hysterectomy, doesn't need a Pap test, if she's 65, she's taking more appropriate forward conversations with her clinicians as opposed to that might just be her annual visit. Why are we doing those Pap tests? Why would we be doing HPV testing on a patient without a cervix? But it occurs. And unfortunately, patients haven't always been in the crosshairs of the decision making. This is to bring patients to the middle of that decision, and I think it's critical. So if you want to know a little bit about the process, I'm not going to go into too much detail, but we had a review panel. We examined hundreds of options, as I mentioned to you earlier. We have a Institute Advisory Committee that basically is housed within the ASCP Institute for Science, Technology, and Policy, where we do a lot of health services research. In fact, Dr. Parks is really our leading advocate and does a lot of work in the health services research arm on the education, helping clinicians understand how to better choose tests, and at the same token, choose the appropriate therapy balanced around those tests. So we looked at hundreds of these, and there was a committee that spent a lot of time, many, many months, whittling through these and categorically putting them in a hierarchy. But we were only allowed to have 5, and that's probably the most frustrating part, I honestly can tell you. If you have to choose 5, which 5 would you choose? I bet you if I polled every table in this room, there would probably be 5 different tests. There may be a few in common, but there are likely would be 5 different tests, which goes to show you that these are hundreds of these examples. But, what we were looking for commonly was common situations, tests with merit in some circumstances, but are not appropriate in others, tests with no clinical utility, tests that have been generally replaced by better tests, but are those tests necessarily specific or sensitive? Are they better tests because they're the latest, greatest fad? Or are they the better tests because they truly do increase or help patient care and are providing a better solution? And then, of course, we looked at issues around new and emerging diagnostics because certainly with the genomic revolution, there's been an explosion of these tests. Obviously, the Silicon Valley of tests right here with respect to all the companies developing companion diagnostics based on those therapeutics have really surged forward or launched us into a totally different choice or proposition for clinicians in order to get involved. Now, I can tell you that I have many, many conversations with our clinical colleagues. There is not a day that goes by that I don't have a conversation with somebody from ASCO or somebody from the American College of Cardiology or whatever about, do we need this test holiday, or is there an opportunity for us to start looking at cutting this out in terms of working my patient up for X, Y disease? And it's interesting because oftentimes you would think, well, my goodness, the oncologists know how to triage breast cancer. They're going to be the experts on triaging breast cancer. But that's not as easy as you think when you've got multiple tests out there that are looking for different rabbits and basically trying to decide which rabbit they should be chasing. And unfortunately, they're really not getting a lot of guidance from us as a profession to help them make those better decisions. So that being the case, I think there really is we envision this as the beginning, again, the tip of the iceberg, to open up that dialogue. Remember, you're physicians, and as doctors, it is your role to protect the patient. And if that means you serving as that liaison or that nexus to the clinician, and or if that means you having a direct conversation with your patient, that means you should be involved. So that's where we're moving. And I'm going to list the top 5 we came up with. And this is interesting, and I'm going to tell you why we chose these. Now, I'm not going to go into all the semantics because I think most of us in here would probably appreciate the same answer. But for instance, why are we performing population-based screening for vitamin D? As most of us know, there is a lot of these tests being performed, and this test is obviously related to folks who might be at a deficiency. And there are some clinical scenarios for which they might be. But for the most part, unless you live in Chicago, you can walk outside and you can absorb the sun. And you probably should get out and walk outside and absorb the sun. Now, of course, in Chicago, you can go to Walgreens and take some over-the-counter vitamin D, or it might be in your supplement. But actually testing, we chose this one because of the fact that it literally was millions and millions of tests being ordered at a very expensive cost with very, very little clinical ramifications. Now, you think about the impact on the healthcare system. Every time I bring one of these up, I want you to think about what that ramification might be in terms of your tax dollars at work. All right? Now, this may seem obvious to you, but you will be very surprised at how many laboratories are still doing low-risk HPV testing. Now, we had to do some surveys and polls, and we had to collect a lot of data on how many laboratories are actually doing this. And of course, you would think, well, what would be the point of it? Because it's not a predicator for determining cervical cancer. Low-risk HPV testing has no relationship to cervical cancer. Okay, it's a self-limiting, typically self-limiting disease. But unfortunately, it's part of the checklist. And if you get to check HPV testing and the clinician chooses to do that, they may check both high risk and low risk. Now, you can bill twice for that, but the patient's getting soaked, and so is the U.S. government. I want you to think about the most common laboratory assay or test there is, Pap tests. Now, do the math. At low risk HPV testing, what did that tell us? It gave us no clinical information as to whether that patient is going to develop cervical cancer. None. Now, this is one we chose. We chose the previous, obviously, because of the fact that it affects a large number of people. But this was one we really, really had to work on specifically because the ramifications of this are pretty enormous. Performing preoperative testing for low-risk surgeries without a clinical indication truly eclipses our healthcare dollars. You would be surprised from all the data that we collected how many people get chemistries done for LASIK surgery. Okay? People are coming in for elective surgery, maybe even for breast augmentation, and they're getting a whole host of laboratory tests that are being run, unfortunately, completely unrelated to the clinical indication for which they were presenting to begin with. Not necessary, but if you think about it, even in your own practice, how often you've got patients with low risk or elective conditions for which they're coming in for surgery, and there's a whole litany or a whole panel of assays that you're being requested to run. Where are we taking that information? And oftentimes what happens, as you know, is there's some suspect ANA test run or something, right? And then we start chasing other conditions that are unrelated to why he or she came in. All right. Now, we decided to pick on this one, or really, maybe that's not the best choice of words, to showcase this one because, as you know, genomics, again, are really eclipsing the number of tests that are out there. And every day, because of direct consumer campaigns from pharma, a lot of patients are thinking they need these latest, greatest tests, okay? They think they need to be worked up for this breast cancer management test or for that or this, that, or the other. But we chose this one because, not because it's not a good test, but, I mean, methylated septin-9 actually is a pretty specific and sensitive test. How many of you know how much it costs in comparison to doing a colonoscopy and just doing a colonoscopy, or even the fecal occult test, and comparing the sensitivity and specificity against those? It is tremendously expensive, and it's the movement. And again, now this is a movement by pharma to pick up the latest, greatest test, but it doesn't necessarily help that patient any better than what you know in your own practice to be the gold standards. We also talked about this from the standpoint that if you think about septin-9, notice the term conventional diagnostics are not possible. So conventional diagnostics are clinical colonoscopy, right? And if he or she sees something, then they biopsy it and you get it. Otherwise, probably not necessary in comparison to other tests that are out there. And then lastly, bleeding time. Now, some of you may, actually, when I was walking up here, I heard somebody say, can you believe they put that on there, bleeding time? Who does bleeding times anymore? Okay, this is very interesting. and I'm not going to pick on anybody in this audience, but I would bet you there's still some folks in this room that do bleeding times. It's not a therapeutic indication, or it's not a good test to determine whether there's going to be coagulation issues related to surgery. Obviously, there are companion diagnostics for things like Plavix, et cetera. But keep in mind that it's an expensive test, and a lot of folks go in for surgery. And clinicians, a lot of them have been trained to think they've got to do bleeding tests. So maybe it's not on your test menu anymore. Maybe it is. But I can tell you that I know a specific example of where, when we released this, laboratories started dropping bleeding times. Immediately, there's already an impact on just the first 5 tests alone. So I mean, not bleeding times, but running the bleeding time test or eliminating that particular test. So I think it's important to keep in mind that small incremental changes do help modify what we do in our profession, but more importantly, will help turn around this unnecessary testing. Now, there's a lot of other primary organizations that looked at tests. And if you actually cross-matrix what those other organizations did and chose and compare it to what we did at ASCP, you'll see that a lot of them are the same. They've fallen into the same formula. And there's some beautiful opportunities across what these, and we've been doing that. But I'm going to show you a couple of these. For instance, here's American Academy of Allergy, Asthma, and Immunology. Okay? Don't perform unproven diagnostic tests such as IgG testing or an indiscriminate battery of IgG tests in the evaluation of allergies. Interesting. Look what Endocrine came up with. Don't routinely measure vitamin D. Interesting. Don't prescribe testosterone therapy unless there's biochemical evidence of testosterone deficiency. We know that one is actually a very common overutilized test. AAFP, which the family physicians probably are one of the larger groups that are at the table as well. I mean, we represent 120,000 people. These represent over 100,000 people. Don't perform Pap tests on women younger than 21 or who've had a hysterectomy for non-cancer disease. Now, you may say, well, there's already guidelines out there for that. But how many of your clinicians follow the guidelines? How many clinicians are aware of the guidelines or turn their back to the guidelines because it affects their clinical practice? So we know there are guidelines that prevent things like this, and I won't go through all of these. But of course, the U.S. Preventive Services Task Force also came up with their recommendations on PSC testing as well as AFP, and they said, look, don't routinely screen for prostate cancer using PSA. I'm not going to go through all these. I just want to highlight a few of them in the interest of time. American College of Obstetrics and Gynecology said, don't screen for ovarian cancer asymptomatic women at average risk. And again, they had a Pap smear recommendation. Rheumatologists, interesting, don't test for ANA subserologies without a positive ANA and in clinical suspicion of an immune-mediated disease. How sensitive and specific is ANA? Okay? And it goes on and on. But interestingly, a lot of these, I mean, you may say, of course, when you get to the radiologist, they're going to talk about don't do MRIs for people who have headaches. Obviously, don't run PET CT scans or radionucleotide bone scans for asymptomatic patients who are being treated for breast cancer with a curative intent. I mean, there's a whole litany of these, but some of them don't fall within the crosshairs of diagnostic medicine. I would say the lion's share of them do. And when I say diagnostic medicine, that's 90% of what medicine does is you. Society for Hospital Medicine, don't perform repetitive CBC and chemistry testing in the face of clinical and lab stability. Okay, so you can review, if you want to, all of these different recommendations at choosingwisely.org. It'll go through them. It'll actually give you, both the scientific rationale, all the evidence base, because this was evidence based. Every single one of these were filtered through an evidence based process, and outcomes based, obviously. So you can go and look at that online if you like, or you can use that as a template for having conversations with your clinicians. We want to point out a couple of things before I turn this over to Becca, and that is that in the face of genomics, we know that we're seeing truly an explosion in terms of the number of tests that are coming online for which clinicians are being asked to use. Now, again, you can say it's direct to consumer, or the clinicians, are practicing from through the lens of medical liability. But for what it's worth, it's still there, and a decision has to be made. How many of these clinicians do you really feel are at the forefront of understanding, particularly if you're in family medicine, at the forefront of understanding what the ramifications and what the sensitivity, specificity, the outcome measurements? Just because there is something on the menu doesn't mean it's a choice they should make. And I always like to compare this to the all-you-can-eat buffet, all right? Is it the all-you-can-eat buffet, or is it the all-you-should-eat buffet? And just because it's on a menu doesn't mean you should order it, okay? You should choose appropriately what's the best test. And clinicians oftentimes don't know. They aren't aware of it. We have to help them make those decisions and help them with their algorithms. A balanced discussion, recommending appropriate tests for individual patients is the downstream consequence. That's what we're trying to effectuate in terms of changes. And diagnostic tests are critical links between patient quality and safety. As I've mentioned to you, you've got to assure there's a valid medical reason to really order that particular test, and helping clinicians understand that and guiding patient management. And why is the test necessary? And are there better alternatives? And is the best test no test? Now you may say, well, my goodness, you're talking about my livelihood. I am. I'm talking about our livelihood. But if you knew there was an opportunity not to produce a test because it doesn't help, think about yourself as a patient as opposed to being a pathologist. Think about your own family, where there have been tests run where you've had to clean up on aisle 9 because of chasing different kinds of activities or tests that are unrelated to the actual clinical suspicion, or perhaps not even related to why. My sister's convinced she has a neuroendocrine tumor in her pancreas. They've yet to find it, but there's an ANA test somewhere downstream or upstream that's proven that she has this, an ANA test. There's a correlation between that and neuroendocrine tumor, apparently. There's no tumor in her pancreas. Well, we don't believe so. All right. So helping educate clinicians and making sure they understand, and helping clinicians help their patients as well is what I mean. Helping them understand that there are tests that really aren't necessary to be performed. This has got to be done at the local level, obviously, but also looking at utilization and determining what are the priorities are necessary at the local level. And we're going to build on that discussion this afternoon and talk about why it's important that we, in our profession, go back to our roots. Let's get back to the basics, okay? We are at the prefaces now of a huge revolution in terms of testing. And yet we understand these tests better than any part of the clinical spectrum of medicine. It is our fiduciary responsibility of the patient to help clinicians decide. So becoming a consultative practitioner is a critical part, I believe, of the future of this practice. And we can improve the diagnostic value of lab tests by preventing the misuse of resources as well. So now I'm going to introduce Becca Rothschild from Consumer Reports to walk us through an interesting discussion around why the patient is the beneficiary. Thank you.
Hi, everyone. Thank you for having me today. I'm Becca Rothschild, and I do outreach for Choosing Wisely at Consumer Reports. And a lot of people think, Consumer Reports, why are they involved with this? Aren't they the ones who test cars and refrigerators? I brought with me the hot picks of 2014 about coffee makers, cameras, iPhones. So what does Consumer Reports have to do with Choosing Wisely? In Consumer Reports, we are influences of consumer behavior. And with Choosing Wisely, it's with health behavior and helping consumers make wise choices about what medical tests, what medical procedures and treatments they need, and which ones they don't need. So recently, I've been thinking a lot about pathology. First of all, because this is the most amount of pathologists I've ever seen gathered in one place in my life. But second of all, I have recently had experience and opportunity to send some of my own samples to pathology. I'm a competitive open water swimmer, and I have been my whole life. And starting about 6 months ago, I noticed a rash and some hives on my shoulders and my upper back. And I didn't know what it was, and I let some time go. And finally, I decided I better go to the doctor about it because this was driving me crazy. And I started thinking about it, and I realized I'd been up in Northern California camping in the fog, and it disappeared. I'd been on the East Coast working and swimming indoors, and it disappeared. But whenever I was here, I had it, and the rash kept getting worse, and it was driving me nuts. So I went in, and I said, I think it has something to do with probably being in the sun or being exposed, because this isn't happening elsewhere. It's not happening in the fog. It's not happening on the East Coast when I'm indoors. And so my doctor said, well, that's probably what it is, but let's order some tests. And I thought, well, what are these tests going to say? What are the risks? What are the options? How much is it going to cost? What if we don't do these tests? What if you just say to me, stay out of the sun for a little while, and we'll see if your rash goes away? But he said, no, we should order some tests. We better find out what happened. So since I work on Choosing Wisely, and since I've been a consumer advocate, I've done health literacy and health patient communication for many years now, I had asked all these questions. But a lot of consumers don't think to ask these questions. They don't ask, why do I need to have this test done? They don't ask what the risks are or what their other options are. So one thing we did at Consumer Reports for this campaign and for all of you at ASCP is we created public service announcements. They're 30 seconds, and each of the different grantees around the country who's working on Choosing Wisely has one that we created specifically for them that they can show to help consumers know what questions to ask. So if you could play the video, please.
You've got a doctor's appointment, and they recommend a test.
Maybe. There it goes.
You've got a doctor's appointment, and they recommend a test, treatment, or procedure. But is it really necessary for you? To find out, Consumer Reports and the Choosing Wisely campaign suggest that you ask your doctor what the risks are, if there are other options, and what happens if you don't do anything. Asking these questions can help make sure you get the right care at the right time. To learn more about Choosing Wisely and the American Society for Clinical Pathology, go to choosingwisely.org/ASCP.
Thank you. Great. So, as you saw, we had to talk very quickly at the end. American Society of Clinical Pathology is a longer name than some of the other grantees. But we invite you to share this. It's in your toolkit, which I know you'll be hearing more about later on. But this is available for you to use in any training sessions and webinars, however you would like. And there's also an audio-only version if that would be of use to you. So what I really want to talk about, though, is that this is a shared responsibility. This is a shared responsibility between the provider or the clinician and the patient. And this is also, again, what I felt like during the situation and when my clinician was saying that I needed to go to these labs for these tests. And I thought, just like this cow, this seems very simple and straightforward. We can figure this out. So there's a shared responsibility between myself and my clinician. The provider was recommending tests that I didn't think I needed. It was up for me to ask questions. Oftentimes, also, the patient will go in and ask their clinician for tests that perhaps are not needed. And it's up to the provider to have that conversation and explain why those are not needed and what the negative ramifications of them are. And what I would do is urge each of you in this room to know that you can engage in that conversation. And even if you don't see patients on a daily basis or on a regular basis, to engage with the clinicians in your systems where you work and talk about the top 5 and why certain tests and procedures may not be needed. To help do that, we've created, we at Consumer Reports have created a lot of consumer-based health information. So we've started by doing 2-page pamphlets for consumers. And you each have on your table one that looks like this. This is the one that we created on lab tests before surgery and when they're needed and when they're not needed. We've created over 54 topics of these in English and in Spanish, and on a weekly basis, we're creating more and more of them. We're also creating one right now on the vitamin D test that was mentioned earlier for your society. We also have, as you see, a poster. This is it right here. It's our 5 questions to ask your doctor before you get any test, treatment, or procedure. And these are the 5 questions that we used for the PSA. This is available for download and for all of you to use. As grantees, you can use these materials however you would like. There's a wallet card, there's brochures. This is another sample just to show you what that looks like that we have on the table, and I'll come back and talk about that in a little more detail in just a moment. These are some additional samples of the consumer brochures, the topics that we've created. So as you see, we have yours up at the top highlighted. These are just some other ones: Lyme disease tests, PAP tests, which was mentioned earlier, stress tests for chest pain, treating sinusitis. This is a big one. A lot of topics on antibiotics are involved in the Choosing Wisely campaign, and the fact that they frequently are not needed and are overly prescribed. This is a sample list of the medical societies and associations that are available, that are included right now in Choosing Wisely. And as you see, American Society for Clinical Pathology is highlighted there. When this started out, when Choosing Wisely began in early 2012, it was thought of as a campaign. But at this point, it's grown and it's become a huge movement. And what we really ask, again, is what can each of you in the room do to help with this movement and to talk with clinicians and to talk with patients to engage on your top 5 lists or any of the other lists. So going back to the brochure that each of you have on your table, I just wanted to walk you through it a little bit. I know you can't see it super well there, but since you all have it on your table, really what this is about is the right care at the right time. It's kind of like Goldilocks, not too much and not too little. And so we highlight on here, there are tests. We highlight why you may not want to have these tests. They usually aren't helpful for low-risk surgery. They can lead to more tests, and the costs can add up. Then if you look at the back side, we talk about when the lab tests are a good idea, because there are times when they are a good idea, and when it is the right care, and when it is appropriate. Then you finally see on the far right-hand side this blue box, and this is how all of our brochures for all of the different topics are framed and how they're all laid out. And what we found in consumer testing, which I'll talk about in just a minute, is that these blue boxes on the right-hand side are what the consumers really like the most, because this tells them what they can do. They already have heard all the things that they should not do, but what they want to know is what they proactively can do and what would be helpful for them to do. So this is where the consumers, what we found in our testing, this is where their eye goes first. While we were creating these brochures, and as I've said, we have these on many, many topics now in English and in Spanish, in plain language, so at a literacy level that the average consumer can understand them. What we found is that they're engaging, they're clear, specific, relevant, and the people liked the look of them, that they were clean, and that they would use them. But in addition to that, what we really wanted to find out was, what are consumers taking away from these materials? Are the materials successful in changing consumer behavior, and will it prompt a conversation with our healthcare provider? So we did a survey with almost 3,000 consumers, 2,669 consumers, asking these types of questions. And to find, and what I have right here are some of our findings. And these results show that these brochures do have potential, high potential for impact in changing how healthcare is delivered within the Choosing Wisely campaign. So first of all, one of our main findings, there's a big theoretical and realistic difference and interest in seeing the pamphlets. So if we just said, are you interested in this concept? Are you interested in learning more? People pretty much said no. But if it was something specific about their care at that particular time, so about sinusitis, about lab tests, about a PAP test, whatever procedure or test they might be going through at that particular time, 72% of them became interested in the topic when it was of relevance to them, which is probably of no big surprise. The pamphlets are written in a clear and understandable language for consumers. And if you look at the fourth bullet there, 43%, almost half of the consumers who participated in this were persuaded to change their opinions based on what they read. So to me, this is a huge opportunity for change and for engagement and for discussion if almost half of them were willing to change their opinions on having a test based on what they read in these brochures. And then finally, participants are willing to change behavior and to take action based on what they read in these brochures. 64% of them indicated they're likely to have a conversation with their provider. And at the bottom, 47%, almost half, agreed that the materials prompted them to ask their healthcare provider more questions. So again, this is a big opportunity to change the momentum and to have that conversation and to change what tests are ordered and to have that conversation. And that's really what this whole campaign or what the movement is about and what I showed in the public service announcement, is having that conversation and encouraging the consumer, encouraging the patient to ask questions. Are these needed? What are the risks? What will happen if I don't have this test or if I don't have this procedure? And arming the provider with the right materials so that they feel that they can have that conversation and know the answers to these questions and know how to engage. And we would also like to invite providers to use these consumer materials that we have as talking points and when working with their patients. Just to show you some of the other grantees, there's 21 grantees around the country. with funding from Robert Wood Johnson Foundation and the ABIM Foundation, working in different ways on the Choosing Wisely campaign. And these are some other consumer-oriented partners that we are working with at Consumer Reports. Just to recap, the materials that we have from Consumer Reports that are available to you to use widely, and I would encourage you to disseminate them and to share them with your colleagues. We've got the pamphlets. I showed you one example of them. We have 5 videos, 2 posters, the one that I showed and one other, the public service announcements, wallet cards. We have a newsletter that goes out monthly, and these are increasing all the time. So all of these are accessible online. You can reach out to me, and I can send them to you directly, or you can get them all at our Consumer Health Choices website. So these are all for you to help arm you with the information you need to go out into your institutions and work on the Choosing Wisely campaign. There we go. And so I still have not done all of the tests, all of the lab tests that my doctor has recommended. I've done blood work. We took 7 vials of blood to find out if I truly am having hives from the sun. And now it's recommended that I go in for urine samples and stool sample, which I have not done. A, because it's not, as you all know, a fun thing to do. And B, because I really don't think we're going to learn anything more. What we're going to learn is there's something going on between me and the sun. So I would like to close at this point by asking each of you to think about a question and to think about something that could be awkward and that could be uncomfortable in your institutions. But to think about what you can do at your own institution to ratchet down the use of these unnecessary tests and these unnecessary procedures and treatments within pathology or in a greater scale within any of the other Choosing Wisely topics that the other societies and associations have brought forth. And what you can do to start that conversation so that the clinicians and the consumers have this conversation and together talk about what they can do to choose wisely and make sure that consumers are getting the right care, the care that they need at the right time. Thank you. And up next, I would like to introduce my colleague, Dr. Kravitz.
Well, it's great to be able to talk with a Congress of Pathologists. Internists and pathologists have worked together for a long time historically. In fact, many of the great internists of old, including William Osler, I believe, did a year or more of pathology before entering the practice of internal medicine. I myself did a month in pathology right down the street at San Francisco General Hospital, and I hope I do my pathology professors no disservice by giving this lecture. I guess I'd like to start by reiterating something that has come through in some of the earlier remarks, and that's how costs have increased so rapidly, healthcare costs have increased so rapidly in the United States, and how a large percentage of those costs, to the tune of $210 billion, really derives from the provision of unnecessary services. A good part of those being diagnostic services like the kinds that are under partial control of physicians like you. I went through some of the Choosing Wisely recommendations of various professional societies that seem to connect with clinical pathology, and I was able to extract these, many of which you've heard about already, but just to run through some spectrum of the diagnostically oriented Choosing Wisely recommendations. The American Academy of Family Physicians, as you've heard, has a guideline on no pap smears for those over 21 years of age or those who've already underwent a hysterectomy. American College of Physicians suggests providing a D-dimer as the initial test for venous thromboembolism in low-risk patients rather than imaging studies. The American College of Rheumatology suggests no ANA subserologies unless there's a positive ANA, and no Lyme testing without an exposure history or findings on physical exam. The American Society of Clinical Oncology has its own set of recommendations. Similarly, American Society of Nephrology and the Society of Hospital Medicine. So there's a number of recommendations that overlap quite clearly with what you do for a living. So if we're to think about ways that pathologists and internists can interact with the goal of more discerning diagnostic test selection. There are essentially three approaches that we could consider. The first is clinical judgment, the second is education, and the third is our new forms of engagement, which we maybe haven't seen so much of to date, and which in fact have been discouraged by current payment mechanisms. But because of the ways in which payment may be changing in terms of accountable care organizations and other new forms of global payments, bundled payments, and other forms of capitation and pseudo-capitation, we may have new opportunities for more direct engagement. So let's start with individual clinical judgment. Under this scenario, internists basically, and other clinicians for that matter, order whatever they want. Pathologists, to be honest, don't help matters because there are many conjoint panels of a variety of tests that are very easy to order in bundles, but not so easy to interpret. And then both, under the current system, reap financial rewards because they get paid an additional fee for every additional test or every additional visit. This is what we might call the Wild West. And it's connected to this picture, which of course is in total contradiction to the Choosing Wisely guideline to not order follow-up immunoserologies in patients with a negative ANA. But these panels like this are ubiquitous in laboratory medicine. And it's just such an easy thing for clinicians who aren't really sure what to order and then see this group of tests all together to just go ahead and with the click of a mouse order these large panels and then be stuck with having to interpret these tests and dealing with the problem we're all familiar with of false positives. So the second approach is education. You do it up in the upper left. You have an annual meeting, I think, in Tampa. We internists do it. Our annual meeting is going to be right next door in Orlando, probably not at exactly the same time, but close. But the problem is that many times standard continuing medical education leads to what you see at the bottom. The student or the individual who's not exactly paying attention, and even if they do, it's difficult to apply what you learn in a lecture setting to actual practice. It's been shown in terms of theories of adult learning that teaching and learning is much more effective when the information is supplied at the time that the adult learner actually needs the information. So that leads to different options for engagement. So I've subdivided opportunities for engagement into electronic resources and direct consultation. So by electronic resources, I'm talking about things like point-of-care guidelines, where as a test comes up, the clinician is provided with information about that test, with lab test interpretation, where the results of the test are interpreted for the clinician, and with risk calculators, which might not seem to be directly connected to laboratory test ordering, but in fact, because the predictive value of any laboratory test depends not only on the intrinsic test characteristics, the sensitivity and specificity of a test, but also on the prevalence of the disease in the population being tested, understanding what the baseline risk, the base case risk of a particular condition is in a patient like the one before you makes a big difference in terms of the value of testing. And then there's this idea of direct consultation, for which, of course, there's no current financial incentive, but as I alluded to, this may be changing. But in the same way that the radiologists are beginning to establish in some medical centers imaging consultation services to help clinicians make more discerning choices about the kinds of radiographic imaging that they do, similar services are starting to be constructed in pathology. But if you do it, it has to be for real, and office hours like this just aren't going to cut it. I actually pulled this from a pathology consultation service that I found on the web. All right, so this is kind of a summary slide which suggests amongst the different Choosing Wisely recommendations issued by a number of professional societies that overlap with clinical pathology, what kind of implementation options might theoretically be available? And I don't think I'll run through this except maybe to choose a couple of random examples. The example of D-dimer as the initial test for VTE in low-risk patients. Education hasn't done much to date, so I'm suggesting that perhaps electronic resources that ask or enable clinicians to figure out the pretest probability of venous thromboembolism and to identify whether their patient is or is not low risk could be helpful in guiding them away from imaging and towards perhaps the initial recommended test, which is D-dimer. Likewise, direct consultation could do the same, and we'll talk about that by way of an example in a bit. And then let's pick another one. No cancer screening in dialysis patients. Certainly, this is something that this is a recommendation that could be promulgated by means of educational sessions, pathologists and nephrologists working together, but also by electronic resources that might just simply raise red flags for clinicians and say, did you realize that if this cancer screening is being ordered routinely, we notice that this patient's on dialysis. Do you really want to do this? Here's the recommendations, and here's some supporting material that would back those recommendations up. This is adult learning at the point of care. So let's take a case example related to VTE, the example we discussed just a moment ago. Let's take this to be a 49-year-old man with right greater than left calf soreness after a cross-country flight. There's no history of venous thromboembolism, thrombophilia, smoking, or cancer, so no risk factors. The exam shows a little bit of pitting edema at the ankles, perhaps greater on the right than the left. The physician, the internist, orders a venous duplex scan just to be sure. But in this case, within 30 minutes of placing an order in the electronic health record, the physician receives a call from a so-called combined diagnostic consultation service, which in this hypothetical hospital is a joint service of pathology and radiology. And this might be the kind of dialogue that takes place. So the pathologist says, picks up the phone, calls the internist and says, thanks for sending in the request for duplex scanning. I took the liberty of computing a Wells score, that's a pretest probability score for VTE, and it looks like this patient is at very low risk. Is there something I missed? Internist, not really. I doubt there's much going on. The patient is anxious and we need some reassurance. Pathologist, did you know that in low-risk patients a negative D-dimer practically rules out VTE? Internist, I vaguely remember something about that. Pathologist, if you want, I can change your order to a D-dimer and have the lab tech call you directly when the result is back. It usually takes about 4 hours. Internist, did you say you're from pathology? So in summary, how can pathologists help internists to choose wisely? You can collaborate with us and with radiologists, the other diagnostic specialty, to develop incisive educational programs and to develop point-of-care guidelines, test interpretation materials, and risk calculators, which can all be posted electronically. And you can work with us to experiment boldly in creating diagnostic consultation services and work with payers and others to make these things a practical reality. So with that, I will end and introduce my colleague, Dr. Haya Rubin. Dr. Rubin is a practicing internist on the peninsula and will offer the perspective of a practicing clinician who sees a great many patients who I think ask for a great many tests.
Thank you very much, Dr. Kravitz. That was a wonderful talk. Again, it's a tremendous pleasure for me to be here to address pathologists. I began my career in pathology. My PhD is in pathology, and it's been a very long time since I've been with an association of pathologists, so I really welcome the opportunity. My comments are going to be made from a couple of different perspectives. And I'm going to just give you a little bit of my own background to explain why as a practicing internist, this has become of interest to me. First of all, I originally came from an academic practice setting similar to the one that Dr. Kravitz is in, and I was very involved there with health policy and thinking about quality improvement and what enabled clinicians to follow practice guidelines and to think about the barriers to following practice guidelines. So a lot of my academic research came from that perspective, so I'll be thinking a little bit about that. The second is that I have, as a practicing physician, been in a setting here in Silicon Valley where patients are very proactive. Some of them are the developers of some of these tests, and they are coming and requesting panels of tests, some of which in some cases I've never even heard of. So I get a lot of pressure from the consumer population to run panels of tests of very questionable utility where I don't even know myself the predictive value or sensitivity or specificity of those tests. And when I look online in all of my research resources, I'm unable to find any information about those things to help me guide the interpretation of those tests. The companies are all very willing to sell these panels, and the labs are willing to construct them, but no one is really willing to tell me what they mean or to go out there and tell the consumers that right now these are pretty useless tests. So those are the couple of things that I wanted to mention. And as many of you are familiar with many of these tests, but we have a lot of genomic testing going on. There are an increasing number of companies in that sphere. You get all of these, 5-panel compendiums of trace elements and minerals and so on, and I'm often confronted with one of these panels that the patient has already done and being asked to interpret, what does it mean that they have low urinary something or the other that I've never even seen tested before, and and they're asking me, what does it mean that my urinary copper level is low? I see in medical school I learned about Wilson's disease, and that's all I really know about copper. So don't ask me any more questions. And then I also want to come from the perspective that there are two major reimbursement sources, and I've been thinking all along as I've been hearing these presentations, I've been thinking, my goodness, what's in it for you as pathologists to reduce the amount of inappropriate testing? How can you participate in this? Your labs run, on budgets that are made up of these lab tests being run. How are you going to be motivated financially and otherwise to create these diagnostic consultation services? And since I'm an internist, I don't even know, do you have a CPT or HCPCS code that you can bill under for a consultation on diagnostic test ordering? So there's really no financial incentive for you to participate in this. And clearly, in order for something like this to get off the ground in a big way, these financial incentives have to be created. And as Dr. Kravitz mentioned, in some of the new insurance schemes, hopefully there will be recognition that you could be very, very instrumental in lowering overall healthcare costs by making this more efficient. The second big sector is, besides the insurance reimbursement system or the government-based insurance system, is the consumer demand itself. And I don't want to ignore that, as I've spent my career thinking about improving patient experience of healthcare. And I do want to put it out there that regardless of what our current policy environment is, consumers really want, sometimes they really want to know about their health, and they have as much right to spend money on knowing about their health as they do to spend it on a Lexus or spend it on a new iPad or spend it on any other form of information or reading a novel or anything else out there. So I'm not perturbed necessarily by 19% of the GMP being devoted to healthcare as long as it's being spent on something that really provides useful information. And what both of these reimbursement systems have in common is that they both need the information from you about what the utility of these tests are. The consumers who are driving the demand at the high end, they would really like to know what this means. They don't want to waste their money. They would like to be buying an efficient product. So they'd like to get something for their money. And so I don't think they should necessarily be discouraged from spending it, but I do think that they should be understanding what it is they're buying. And you can play a very critical role, it seems to me, in both of these systems if you are able to provide that key piece of information. I would certainly be advocating very strongly, if I were a member of this organization, for my organizational leadership to be working with payers and with the government on creating more jobs and roles for pathologists in diagnostic consultation and test interpretation. I think that's where the future is going to lead. Dr. Kravitz talked a little bit about electronic resources, and I want to think a little bit about the forums for education that are available for pathologists to enter into this discussion with both physicians and patients. I don't think that internists perceive pathologists who intervene in these situations or radiologists to be heavy-handed at all. I know that as an internist, I very, very much welcome the input I get from a lab. When I get a lab report that actually says on it, here's what this means, when it gives me a very nice list of the laboratory reference values with a scholarly indication of what the predictive value is for those different categories for some clinical outcome, I feel extremely happy. And so, because I need that information, I'm a general internist, I'm asked to do tests in all kinds of different disciplines and to interpret them. And the more information you give me, the happier I am. So in no way do I think clinicians perceive this as, slapping their hand. If you called me to tell me, now why on earth did you order this vitamin D level, or you gave me, even better, a little algorithm when I order the test electronically that says, does the patient have an abnormal calcium level? And you ask these few questions and then have a little, well, did you know that in this situation, vitamin D has no predictive value for any unusual outcome? Then I would be less likely to order the vitamin D level in that case. Even if the patient is asking me for it, it gives me a tool with which to tell them, hey, you may have heard our vitamin D levels are low, but the truth is we don't really know what that means for someone in your situation. Secondly, I think you can work a lot on your reference values. I see different reference values out there for normal for lots of different tests, and I don't know what justifies those different reference values. So it would be helpful to have some references or some referral to sources about why certain tests are normal or abnormal. So I think that you can take the high road. You can include these algorithms for appropriate use. And rather than seeing this as diminishing your budgets and in your financial capacity to operate as departments, it makes more room for other tests that may selectively be important. I have so many patients who really could use, for example, BRCA testing to guide their screening algorithms for their children and their grandchildren for breast cancer, and yet they're not getting those tests because nobody's covering them or they're not financially able to do so. So it really makes more room in the healthcare dollar for appropriate testing that could be used better for things that we do know do have predictive value and utility in certain situations if we can eliminate some of these grossly overused screening tests. I'm going to wrap up my comments there, and I just wanted to have a show of hands as to whether any of you are actively doing diagnostic consultation right now or reaching out to your surgical or internal medicine colleagues with active interventions to guide them in their test ordering, so I could understand if that's just pie in the sky right now, or if this is actually going on in some settings in a way that it's not in my own. So it's great to see that there are some innovations in this direction. Thank you very much. I'm sorry, I forgot to introduce our capstone, Dr. George Lundberg, who is, as you know, has been a leader in this field for many, many years. He mentioned to me at lunchtime that he actually wrote a book on this subject, or 2 books, did you say, on the order of 20 years ago. Didn't you say that? Oh, longer than that. So with no further ado, let's welcome Dr. Lundberg, who for many years was the editor of JAMA and is going to wrap up and synthesize much of what we've been talking about here today.
Change is everywhere. We're all caught up in its swirl. What to do? What to do? I appreciate all you guys hanging around. I mean, it's Saturday and there are football games on and it's a beautiful day outside and all that shopping and stuff. So thank you very much for being here. We appreciate it. At the end of the session, which is at 2 o'clock, Dr. Parks wants to be sure that any of you who are actually interested in what we're talking about, and I would assume it's all of you or you wouldn't be here, we'd like to know who you are. We'd like your cards or some kind of identification so that we could potentially follow up with an interaction between the Choosing Wisely ASCP CSP approach, the funders of this conference, the Robert Wood Johnson Foundation, and you, to see if we can't work together to help California to be in the lead, as it is in so many things, in actually making some of this happen. So I would appreciate that kind of information at the end if you can bring it. I don't have any slides. I didn't know what I was going to say until a few days ago, or actually some of it today, because I'm the wrap-up, the final speaker, and I had to hear what other people were going to say, etc. In addition, I had the great privilege of being in Boston, Massachusetts, most of this week at a conference among the people who created the Choosing Wisely movement. And a spin-off of that has been the Lown Foundation of Bernard Lown of the Nobel Peace Prize that many of you will remember of that fame. That foundation has now the Choosing Wisely concept as one of its main activities. It had a 3-day meeting in Boston, and it 20 months ago had its first meeting on what they call avoidable care, and that's already morphed into from avoidable care to right care. So the Choosing Wisely doesn't only mean don't do that, it also does mean do this for the right reasons. Many things change, many remain the same. One factor that has remained immutable was Mick Jagger with the Rolling Stones in 1969 when he wrote and sang, "I can't always get what I want." Repeat 3 times. But then if you try sometimes, you just might find you get what you need. This whole thing has to do with what do you want, and that's what everybody gets into doing and keeps doing and keeps doing. And what do you really need? And we've had a runaway culture of over everything for way too long. And now, thankfully, large numbers of thoughtful people are really trying to figure out a way to stop that train from going so fast and to move it back in some fair way. One of the books that Dr. Rubin referred to was Managing the Patient-Focused Laboratory. I wrote this when I was running labs at the LA County USC Medical Center in the 1970s, and this book, although 40 years old, is talking about choosing wisely and organizing a laboratory along to meet the patient's needs, not the laboratory's needs, et cetera, et cetera. And a lot of the things that are in it, it's been out of print forever, but a lot of the things that are in it are extremely applicable to what pathologists and others ought to be doing now. It asks in a preface, what laboratory tests should be done and when? Who should do the tests and where? How much should the test cost and why? Should quality and turnaround time be assured and how? One entire chapter was devoted to laboratory request forms that guide and report forms that teach. That's exactly what you're talking about. And some of you may have been at the big county back in the 70s, but we created a whole lab based on turnaround time for clinical need to make decisions that mattered to the patients, not just because an instrument could do it. And we eliminated the concept of stat tests by organizing based on turnaround time 24/7. Because when somebody gets sick, they get sick. It doesn't make any difference what time it is or what day it is. Anyway, those lessons are there. Most laboratory and other diagnostic tests that are done don't need to be done. Yes, I said that. The results of most laboratory tests are normal, negative, or show no change from the prior test result. I love one of these Choosing Wisely thing which says you don't have to do a CBC every 10 minutes or every 10 hours or every day just because it's protocol when things seem stable. That's what I'm talking about. Laboratory tests should not be ordered without a plan for how to use the information that is gained. And this led us to the concept out of LA County that I wrote about in JAMA. I conceived in 1969 and 70, but we wrote about in JAMA in 1981 called the brain-to-brain loop, which dealt with pre-analytical phases, post-analytical phases, and an entire loop defining a laboratory test, not just doing something in a test tube and coming out with a result. And there'll be more about that, because once the ordering happens, the ordering physician or the ordering patient begins a cascade. And that cascade has been termed by some investigation momentum. You get the thing started and you can't stop it. You get on the train just keeps going. The way not to get on that train, the way not to get that whole thing going is you don't do the test at the front end. Why do physicians order laboratory tests at all? Well, we studied that in the 70s and wrote a report in JAMA at that time that indicated that the traditional reasons were diagnosis, monitoring, screening, a previous abnormal result, prognosis, education, and medical legal, with a breakdown on those things. So in order to confirm those findings, I used to do Socratic teaching sessions about how to use the laboratory around the country, actually in other countries as well. And I would talk to people right on, laboratory people, clinical people, about, well, why do physicians order laboratory tests? And I began to get answers in addition to those traditional ones. And there are such things as to confirm a clinical opinion. Okay, that's sensible. To establish a baseline. When I was chair of pathology at UC Davis, we had an orthopedist who ordered blood gases before every knee operation, like on athletes. I said, why do you need a blood gas on this 20-year-old guy who's having a meniscus operated on? He said, I need a baseline. What? Look at him. Is he blue? You don't need to establish a baseline. Normal values establish a baseline for most things on most people. Next, to complete a database. Are you kidding me? You never have a complete database. The test of a good clinician is how little data are necessary to do the right thing. The bad doctors have to get large amounts of data, and then they still do the wrong thing. Curiosity, I just wondered what it would be. Insecurity, I don't know. Maybe I'd feel better if I got a lab test. Public relations, oh yeah. And your marketing people at your hospital can help you with that one. Documentation, you better put in the chart. Peer pressure, Dr. So-and-so is doing them down the street, I better start doing them. Patient pressure, the patient made me do it. Pressure from recent literature, the New England Journal reported on serum mayonnaise, we better get that done on this patient today. You mean you don't offer that test? What is wrong with you, pathologists? You're supposed to offer that test. Question of accuracy of prior result. I don't believe that lab test. I better get another test on it. When I was working at Letterman Hospital here in the Presidio, back then there was an Army hospital here, we had one doctor who ordered 130 serum calciums on one patient over a period of about 2 or 3 months because he was trying to figure out whether there was a parathyroid adenoma or not. And he didn't believe this one, then he didn't believe that. Yeah, okay. Unavailability of prior result. Can't find the damn thing. I better get another one. Personal education. How am I going to learn how to use this test if I don't try it? Research, sure. Personal reassurance, okay. To show to an attending physician. At LA County, I tried to get the attendings to say, why did you order that instead of, why didn't you order that? They wouldn't do it. Maybe now they will. Are you going to get attendings to do that? To say, why did you order that? Okay. Hospital policy. The hospital made me do it. State legal requirement. The state made me do it. Concern for liability. Oh, yeah. CYA. In Chicago, that's Catholic Youth Authority, but here it may be something else. Personal profit. Really? Oh, yeah. Hospital profit? Oh, yeah. Fraud and kickbacks? Yeah. Hunting expeditions. Fishing expeditions. It's the same thing. Frustration had nothing better to do. I don't know what's wrong with this patient. I better get some lab tests to buy time. Maybe if I order some lab tests, by the time they come back, I'll have some idea what's wrong with this patient. Simple availability. They were there. It was on a request form. It was in the computer. All you do have to do is check it. It was there. There's a lot of similarity between, I've worked in the drug abuse field a lot for a long time, ever since starting to work with the LA Free Clinic, actually, and the Foothill Free Clinic. But there's a lot of similarity between doctors ordering laboratory tests and people taking psychoactive drugs. It's there. I think I'll try it. I liked it. I think I'll try it again. And then it becomes positive reinforcements, habituation. And then if you can't get the test, you get tolerant to do it. I mean, you can take the drug, you can order the test, you're very tolerant to that, it's normal. I'll order all these tests, no, but nothing happened, it's okay. And then if somebody comes along and says, you can't have that test, there's mental tolerance, probably not physical dependence, certainly habituation. I've never seen, there's withdrawal. If you can't order that lab test, you definitely have withdrawal symptoms, you, the clinician. But if you, I never saw a clinician have an actual convulsion when they couldn't get that lab test, but damn close. A lot of similarities there. At the Boston conference where we just were, I'm going to give you 7 take-home quotes. They're not in any particular order, but I just wrote them down a few days ago. Elliot Fisher, he's the guy who created accountable care organizations at Dartmouth. He's the small area analysis guy along with John Wenberg. Elliot says, think globally, act locally. All medical care is local. Albert Einstein, he wasn't at the conference, but he was referred to a lot because he said, among many things, the unleashed power of the atom has changed everything except our modes of thinking. What we're trying to do with you and with your patients of being here is to change the mode of thinking. You, us, and the groups with whom you work. Wayne Gretzky, of course, famously said, you skate to where the puck is going to be. A dean of a medical school said that the academic medical center is the greatest resource trapping device ever invented. And it trains all those people to do like that. Less is more. Value, not volume. Vikas Sainai, the president of the Lown Foundation, says, The American healthcare system is a wealth extraction machine. And Bernard Lown, who did address the group, he's 93 now, said, this is the take-home message today, amongst all the things here. Do as much as possible for the patient and as little as possible to the patient. They did a survey of the 300 people who attended this conference this week. In advance, had about 92 people participated in advance. One question in the survey was, what percentage of health care in America, in your opinion, is unnecessary? And the scan was, most everybody said between 25 and 40%. And these are people who were really into this. This is where they were. Then they gave us 8 things that were called primary drivers of overuse, and they asked the people to list the top 3. And here's how they came out. It was about a 35% response rate, all before the conference. These are the big drivers, they thought. Number 1, patient unrealistic demands and expectations. Physician habits and culture. Physicians engaging in defensive medicine. Physician economic dependence on volume. Hospital economic dependence on volume. The drug and device industry. The fee-for-service payment system. The supply, number 8, the supply of healthcare resources such as beds, imaging devices, and clinicians. Incidentally, I'm famously on the record as saying the best hospital bed is an empty hospital bed. So here we go. How did these things shake out? Well, I gave them my top 3, and I didn't win. Number 1 from the group by a big margin is physician habits and culture. Number 2, the fee-for-service payment system. Number 3, patient unrealistic demands and expectations. Tied for 4th, defensive medicine and the drug and device industry. 6th, hospitals' economic dependence on volume. And tied for 7th, the last 2, physician economic dependence on volume and the supply of healthcare resources such as beds, imaging devices, etc. There are lab tests you really do need to do. There are others you really don't need to do. And to try to figure out the difference, you try to fit that out. One that you really do need to do have with those things that could create critical values that you need to act on right away. And just for historical reasons, this is the original chart in 1972 that began the critical value system in America, the panic value system that we published in Medical Laboratory Observer, a non-peer-reviewed throwaway that changed practice in American laboratories within weeks. This chart went up on everything as a centerfold. Back then, we used centerfolds a lot for various purposes, and that was there. So that's the original panic value paper. You can change the world, but those are the kind of things you really ought to do. The brain-to-brain loop I've talked about, that was in 1981. But if you want to look it up, look to AJCP December a year and a half ago. It's the brain-to-brain loop concept of laboratory testing 40 years after its introduction. Pre-analytical, post-analytical, that's what Choosing Wisely is all about. That is the future of laboratory medicine in the United States of America and many other countries as well. One final, actually 2 or 3 final notes. Laboratory tests that matter. Many of you probably know we ran a column in JAMA for many years called Toward Optimal Laboratory Use. ASCP published the book based upon that called Using the Clinical Laboratory in Medical Decision Making. And it introduced algorithms. Larry Weed and I worked out algorithms for diagnostic purposes for laboratory testing, and for decades published about that, including in the book. But in an ACO, you get rewarded for doing less and having healthy people. Keep the people healthy, treat them right when they're sick, and prevent premature death. save money, and split the profits. There are two wildly different approaches I would take to that. One is the simplest lab test I know that could save an ACO ton of monies. The simplest one is a medical device called the bathroom scale. Everybody in the ACO ought to be required to get on one every morning at the same time, report on it, and never let that number go up. That's a simple one. That one works. That's a really good lab test. Great sensitivity, great specificity, great action capability. Very simple approach, but very good. The second is my conflict of interest, which is my main job these days, which is as Chief Medical Officer of a company called Collabrx, C-O-L-L-A-B-R-X, which does applied oncogenomics. Our office is just down the street here. We use expert systems and computer artificial intelligence to interpret next-gen sequencing coming off of the various machines that are doing it. And we are doing this for Quest nationally, also for University of Chicago, Stanford, other places. If any of you have labs that are doing these and you need interpretation of that complicated genomic information, our company does that, and we'd be happy to talk to you about that. Third thing about lab tests, there's some you should never do, like the PSA. Don't do it. A pathologist started that one. He apologized in the New York Times with an editorial called The Great Prostate Mistake, where he did penance in front of the entire New York Times readership, apologizing for discovering PSA. He said, no lab test has ever hurt so many people. And finally now, the American Academy of Family Physicians said, don't do it without a really good clinical indication, and there are not very many of those. If you want to know how to take a system and change it, my last JAMA editorial tells you, December 16, 1998. It's called Changing Physician Behavior in Ordering Diagnostic Tests. There are steps 1 through 8, based on John Eisenberg's original work published in JAMA, followed up in the New England Journal a few years later, on the 6 ways to change physician behavior. You can change physician behavior by education, feedback, financial rewards, financial penalties, administrative changes, and physician participation. Out of that, I produce this 8 points of how to do it. If you want to do it, you're not going to make it happen yourself. You need colleagues. You need to get together as the brainy people who really want to be with it as we change our U.S. healthcare system going forward.